Hey, this is Dr. Raj here again. This topic is actually on the various different anemia overviews, so microcytic, normocytic, and macrocytic. I'm just going to briefly go through each one, and then in the subsequent videos, we'll talk about each and every condition that belongs to each of these three categories. So the first thing you want to do before we get into the three categories is all anemia patients, we should discuss the evaluation. So initially you assess the patient's hematocrit, MCV level, reticulocyte count, peripheral blood smear. That's common stuff. And then for each type, you would do a follow-up test with a specific component. So if microcytic anemia, then you follow up with a ferritin level, iron level, TIBC level. If it's a macrocytic anemia patient, then you'll follow with the RBC folate level and also serum B12 level. If it's a normocytic, then you'll follow up with a Coombs test, iron studies, bilirubin, because there's a lot of hemolytic anemias that fall under normocytic. So basically, the common stuff: hematocrit, MCV, reticulocyte count, peripheral blood smear. That's common. That's any anemia initial assessment. And then if it's microcytic, ferritin, iron, TIBC. If it's macrocytic, then folate and B12. If it's normocytic, then Coombs, iron, and bilirubin. And then you also want to screen for malignancies because malignancies can cause anemias. And you also want to screen for haptoglobin levels because of the hemolysis component, and the guaiac tests for, if there's a GI bleed. Now the differential, let's get into the three different categories. First category is the microcytic anemia. Microcytic anemia is actually, just the thalassemias, lead poisoning, and the iron deficiency, along with the sideroblastic anemia. So with the iron deficiency, it's straightforward: low ferritin, low iron, high TIBC. Thalassemias will have an increased hemoglobin F. That's the key component. That's what you're looking for. And then low MCV, because this is a microcytic, and then hemolysis, because thalassemia is actually a hemolytic anemia. Sideroblastic anemia, you'll have that ring sideroblast that we talked about earlier. That's classic for sideroblastic anemia on a peripheral smear. But you also have high ferritin, high iron, and a low TIBC. In a lead poisoning patient, you'll have low MCV, obviously it's microcytic, basophilic stippling, and you'll also have increased free erythrocyte porphyrins in the lead poisoning patient. And then macrocytic, B12 and folate deficiency are the two common ones: increased MCV, increased LDH, decreased haptoglobin. This is if it's leading to a hemolytic anemia. A hemolytic anemia falls under two categories: mechanical, not falls under, it has two categories that fall under it: mechanical and immunological. So if it's mechanical, you'll see an increase in reticulocyte count. If it's an immunological reaction that's causing the hemolysis, you'll see a positive Coombs test. So a Coombs test is what you would do if you're suspecting an immunologic hemolytic anemia. Drug exposure is also a cause of macrocytic anemia. And drug exposure usually refers to three common drugs that cause macrocytic anemias: phenytoin, phenobarbital, and methotrexate. So if you have a patient that's taking methotrexate, if you have a patient that's a seizure patient with phenobarb or phenytoin, you could possibly get macrocytic anemia, and that's what you'd want to check. Now there's a condition called Diamond-Blackfan, and that also is commonly tested, and that is classic for a macrocytic anemia. Diamond-Blackfan is a congenital pure RBC anemia with classic features symptomatically of triphalangeal thumb. So basically a very long thumb that almost looks like a finger, and a webbed neck. So triphalangeal thumb and a webbed neck along with a pure RBC anemia, you're thinking Diamond-Blackfan. Then the normocytic, you'll have hemorrhage that can cause normocytic. You have chronic disease such as renal failure, chronic renal disease, infections, bone marrow disease, and then you also have, and so these are the hyperproliferative. Then you also have the hemolytic normocytic, which, intrinsic and extrinsic. Intrinsic is G6PD and hereditary spherocytosis, but extrinsic is cold agglutinins, autoimmune, and mechanical destruction. So with the hemorrhage, you'll have to watch for the CBP, not really the hematocrit. CVP is much more important. But then with the chronic renal disease, you'll see a high ferritin, low serum iron, and low TIBC. That's classic of chronic renal disease that's leading to a hyperproliferative normocytic anemia. High ferritin, low iron, and low TIBC. Whereas in the iron deficiency, it was low ferritin, low iron, and high TIBC. So it's like the opposite of iron deficiency anemia. Infections will mainly referring to osteomyelitis, HIV, mycoplasma, and EBV. And these are the same infections that will also cause cold agglutinin extrinsic hemolysis, hemolytic anemia. So, and then lastly, the bone marrow diseases that cause normocytic anemia are leukemias, lymphomas, and myelodysplasias. In terms of intrinsic hemolysis, so G6PD and hereditary spherocytosis, the only thing you're really after is that decreased serum haptoglobin. And then in the extrinsic hemolysis, like cold agglutinins, you'll have, like, again, osteomyelitis, HIV, mycoplasma, and EBV, Epstein-Barr virus. There's also autoimmune extrinsic hemolysis. So in that, you'll see an increased LDH, increased potassium levels, bilirubin, and decreased haptoglobin. And then lastly, you have mechanical destruction, which is also considered an extrinsic hemolysis. And mechanical destruction, basically like when red blood cells, get sheared up when they hit a defective heart valve, but there's also microangiopathic hemolysis that falls under the same category of mechanical destruction, such as TTP, HUS, and DIC. So thrombocytopenia, the thrombotic thrombocytopenia, the hemolytic uremic syndrome, and then the DICs. So those are basically the points that sum up the anemias. Thank you.